Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Welcome back to another episode of the Prescription for Admission podcast, where we talk about hospitals. I am Dr. Nugent, your host. I'm a practicing hospitalist and also author of a book by the same name, Prescription for Admission, where I talk about a lot of the same topics. This podcast is dedicated to hospital experiences for patients, their caretakers and loved ones, and also healthcare providers as we work in that space. Today is another episode of Pediatric Hospital Medicine, which, if anyone's listened to for a while, knows that I have a passion for inviting pediatricians to come and speak to us because that experience of navigating the hospital as a pediatric patient, as a parent, as a caretaker, as a guardian is so very different from the adult world. And so I'm excited again today, as I'm always excited when I have pediatricians on here, to speak with Dr. Nakia Jacobs-Pratt, otherwise known as Kay. So Dr. Jacobs-Pratt is a pediatric critical care physician, author, and healthcare equity advocate based in Chicago. Her passion for helping patients in the pediatric ICU led Dr. Pratt to creating inclusive hair care kits to help children feel seen and cared for during their hospital stay. That effort grew into a wider initiative, bringing inclusive healthcare supplies to 6 states. This is amazing. Thank you so much for that. Her work has been featured by Essence Magazine, Good Morning America, and her debut children's book, The Magic Bonnet, which we're going to talk about. The Magic Bonnet, Zoe's Hospital Adventure, celebrates healing, representation, and the power of Black hair joy. Dr. Jacobs-Pratt, Kay, thank you for being here. Thank you.
Thank you for having me. Thank you for that warm introduction. I appreciate it. I'm excited to be here as well.
Yeah, so Kay and I have a love for hospital medicine, for being in the hospital and caring for people at their lowest point, at their sickest point, and their family members as well. And so I'm really excited to talk about the experience of the PICU, Pediatric Intensive Care Unit. I've mentioned a few times on this podcast, I am a NICU mom, neonatal intensive care unit. One of my children spent a little over a month. I'm also a PICU mom. I had a very short stay in the ICU for a respiratory virus that we never found out what it was that caused some respiratory distress. But I will tell you, as a parent, as a physician, all that goes out your head. You're a parent. You're in the ICU. Your child is in the ICU. Oh my God, your child is in the ICU. So that is an intense experience. And I'm so excited that you're here to talk to us about that work.
Yes, super excited. I hope that your experience in both ICU settings was something that you felt like, empowered through and that you had a better understanding with. But I never realized how little was known about what exactly a PICU was until I started your fellowship. And I would tell people that I'm a PICU fellow and they'd be like, oh, like the NICU. Or I'd talk to family members and they'd be like, oh, you deliver babies. And I'm like, no, not that either. And so I never really understood that we were just a space or a gray area that people just knew very little about.
Yeah. So I think the issue is when we talk about pediatric medicine in the lay space, we have an idea of kids going to see their pediatrician for cuts, scrapes, immunizations, well-child checks. But the doctor in the hospital is just kind of limited to, I had a baby. Look, this new baby. And unless there's something that sends the baby to the NICU, people have an understanding of what a NICU is. We've talked about preemies. There was March of Dimes that was all about helping premature babies. So that idea of being born just a little bit too early, or as my neonatologist said, being excited to join us, right? Coming just a little bit early is kind of new, but there's a space from neonate all the way to 18, 19 years old where you can get sick. Exactly. You can get hurt. Right? And so those really intensive illnesses need to be cared for by pediatricians who have more training. So can you tell us a little bit about, you said fellow, what is that journey for the students and residents listening? What is the journey to becoming a pediatric intensive care unit attending?
Yes. So first we got to get through medical school, right? And medical school is that area where we finish college. We've either gone straight through medical school or straight through to medical school, or we've taken some time off, but we're all like together, right? Same playing field, same 2 years of coursework, same clinical exposure. And during medical school, I felt like I knew very quickly I wanted to do pediatrics, and I had no clue going into medical school that that's what I was going to do. I thought I was going to do OBGYN. And then I had my first OB-GYN rotation and was like, this ain't it.
There's a lot of... I love if people do it, but like I was excited to do it, and I was like, this is a lot wetter than I anticipated.
Yes, that room, and there's that board with all the laboring moms in here. I'm like, this is not for me. So I realized on my OB-GYN rotation that I wanted to go with the baby. So I knew that I was going to do pediatrics then, although I am a strong advocate for the fact that we don't expose medical students enough to pediatrics, but it's a different hill. So then I said, okay, peds. Went on to do pediatric residency, which was the 3 years. And during residency, emergencies always found me. Whether or not I wanted to be there or not, there was always something going on. To the point where I'd walk in the hospital and people would be like, oh man, we know what kind of day it's going to be. And I found myself not being able to deny the fact that emergencies found me. I actually enjoyed them. In the moment, sometimes I thought, why me? But afterwards, I always felt good about the medicine. Like I'd get in my car and be like, well, that was dope. And so I said, I've got to go on and do critical care fellowship. So that was an additional 3 years to then do pediatric critical care. So they're both 2 different board certifications, pediatrics and then pediatric critical care. And for those listening, there's additional fellowships you can do following pediatric critical care. Like you can do neurocritical care or pediatric cardiac critical care, which are additional 1 to 2 year fellowships. But I stopped after the peds critical care fellowship.
For those of us in internal medicine who go on to critical care, there's also another avenue from anesthesia. Mm-hmm. Is that also an availability through pediatrics?
Not as readily available as it is in the adult side of things. Yeah. There are people that go on to do some pediatric anesthesia after like pursuing critical care and doubling up that way, but it's not a pathway like in the adult side.
Okay, so they tend to double up.
Yes. Mm-hmm.
Yeah. So I think that's really important to understand because there's so many different pathways to careers in medicine. And though we were joking about not loving OB, there's somebody who did love it. And that's the great thing about medicine is that something's going to click for you. If you're in medical school and you're just kind of slogging through these rotations, something is going to click for you. And it may be the thing you didn't expect. So just keep your heart, your mind open to those experiences. And that black cloud experience as a resident where like all of the things happen. Yep. I luckily wasn't that resident unless I was in the critical care.
Okay.
So like if I was on the floor, it was like, all right, I can have a regular day. But I felt like when I was in the unit, everything went wrong. And maybe that's also the nature of the unit.
Right.
And and that's where, again, right, those things click for different people. For me, when I did my ICU rotations, it was a ton of fun. I loved my co-residents. I loved the attendings. I lost weight. I lost like 5-7 pounds every time because I was stressed. I wasn't eating. I wasn't sleeping. Yes, it was stressful. And it wasn't an environment that I thrived in. But some people, like, I had co-residents who went on to in critical care medicine, loved the intensive care unit. It was like the exact opposite, where it was like, I wasn't eating. They were like on the floor with a sandwich, like chowing down, having a great time, up all hours, And so I love that there's that space for everyone in medicine. So keep your eyes, your ears, your heart open to those experiences as you go through your rotations, including residency. Like, it's not the end of it.
Correct.
Yes.
That's such a big misconception that you just go to residency and that's the end. Like, this whole career is like a continuum. Even in attending ship, I have learned that this is not the end. Like, it doesn't have to be the end. There are other certifications. There are other administrative roles. Like, there's so many choose your own adventure opportunities here that you just kind of got to buckle up. Because this is an ongoing journey and you like have committed to being a lifelong learner. So it's not really an end. It's, it's growth. It's continual growth.
Yes. And I want people to hear that, what she just said. Like, it's continual growth. It's choose your own adventure. It is hard sometimes to be in this space clinically where you're seeing a lot of patients, right? You have metrics to meet, right? Are your RVUs, and that's going to be a totally different conversation, being met? What are your quality measures? This, and it's hard. And sometimes I meet physicians who feel very stuck.
Mm-hmm.
And I love what you just said. You're a lifelong learner. Go out there and learn about you, the thing that is still passionate in you for medicine. And
Right.
there's a way for that to help you grow.
Yep.
So that's awesome. Thank you so much for sharing that journey. So the Pediatric Intensive Care Unit, it's not cuddling babies.
It is not. No.
What is it?
No. It is a play, and I'm so glad you termed it as cuddling babies, because I feel like there's so many people, even in healthcare, even within the hospital, that I'll bump into in the physician's lounge or other places, and they're like, "Oh, you guys are playing with babies," these types of things, and it is far from playing with babies. Although I enjoy a cute little baby, that is not what we do. Pediatric ICU is where children come who are facing life-threatening illnesses.
Yes.
So every day we deal with life or death.
Yeah.
We deal with making decisions that could alter someone's life forever. We deal with making decisions that could determine whether or not someone lives. Yeah. And there is a huge weight and responsibility that comes with doing that on the critical care level. And I'm biased because I'm peds, but also on the pediatric level, because these are children. This is the next generation. You could be saving the future, Surgeon General, the future whatever. Like, you are saving the next generation of people, the people who will care for you, the people who will make decisions about you in the years to come, and people who are innocent, right? The reason why many of us go into peds, at least for me, was that I get the pleasure of caring for someone who doesn't deserve to be there. They didn't choose to be born. They didn't choose this life. They didn't choose this circumstance. They didn't choose this illness. They didn't choose whatever happened to them. And for me, that made me very passionate about being like, I must come in and I must help, because you have come for help. You didn't ask to be in this position. And it's my responsibility to help you dig your way out of it.
Yeah. Yeah. There was a pediatrician I spoke to not too long ago, a little bit of an older gentleman, and he said back in the 80s when I was in residency, the experience of a hospitalized child was a usually fairly normal, healthy child who got very sick, came in and got very much better. And now when I'm in the hospital, I see that the hospital medicine attendings, the PICU attendings, they're dealing with patients who are a lot more complex than what I was seeing in the 80s, children who have a lot more medical needs. And I was just kind of hoping for an insight, because here was, hospital medicine, a lot of these in specialties and how we support acutely hospitalized people didn't really exist in the 80s and 90s. A lot of this came about, but pediatric ICU I know has been around for a bit, but the thinking about hospitalized patients as a different set of patients who need to be supported differently in this short space and afterwards.
Right.
What comes afterwards is somewhat in medicine a fairly new thought process. Right.
Really?
And yeah. And so he was like, man, in the 80s, it was a whole lot of like pneumonia, and then people got better. And when I am in the hospital now, it's a different world for kids.
Very different. Technology is different. Like, the things that we can do and offer are very different. I mean, every few years we're coming out with new medications, new technology support or assist devices, like all kinds of things that allow us to support people better, that allow us to address mortality and morbidity in different ways. Like, there was a time when babies came in with bronchiolitis, everyone got intubated, right? Like, just intubate. Now we've got so many devices beforehand.
Can I push you back a second? What is bronchiolitis?
Bronchiolitis. So that is usually caused by a viral infection in babies. So we see it more heavily in respiratory season, and we see it normally in younger kids because their lungs are less developed than bigger children. So they are more likely to get mucus plugs and increased secretions from having a viral infection. Unfortunately for babies, they're not as strong as you and I are to be able to breathe through that stuffy nose, breathe through all of the mucus. And even as adults, we get stuffy nose and mucus, and it is like the most miserable.
Yes.
And for a baby who is miserable and also can't control it, also does not have a productive cough, and also does not have the musculature to take those good breaths. So those babies come in with respiratory distress and sometimes even respiratory failure, where they need to go on devices to help them breathe. And I explain it to parents that, like, the lungs are a balloon. And when you think about blowing up a balloon, The hardest part is when you first start, like that first little bit of blowing.
Yeah.
And then once you get it open a little bit, then it's a little easier. The devices that we use help the babies keep it open that little bit so they don't have that full collapse from all of the secretions, and then help them breathe on top of it to keep blowing up that balloon. So when they come into the hospital, before we would have to place a breathing tube directly to the lungs to give that pressure for the balloons. Now we have other devices that don't require a breathing tube that can go in the nose or around the mouth to help give that pressure to blow up the balloon until the baby's able to fight the virus.
Right. And so, yes, that idea, that thought process, that technology changes, the way we treat patients changes, but also what you're doing, Kay, with pediatric patients leads to what I see later, things that kids used to pass away from, like cystic fibrosis. I remember being a little kid and hearing about fundraisers for cystic fibrosis. And cystic fibrosis in the 80s, 90s was kind of considered a fatalish disease. Like these kids did not grow up. And now I treat people with cystic fibrosis, adults, because we have been able to support them and treat them with different medications, different technologies. When I did my pediatric rotation, the pulmonologist let us try on the vest for cystic fibrosis, and it's this vest you put on and it shakes, like does percussion. And I thought that was like the coolest thing in the world. That we have got all these different ways of helping people to grow to their full potential. But when, for instance, when I sent my child to the PICU, I was sending her to a friend. I have a friend who's an intensivist at a hospital in the Boston area. And so I had the luxury of calling, hey, we are sick. She's in an ambulance. She's going over. I happen to know you're on call. So thank the Lord that I know the person who's going to be accepting my child. But I still stopped in my tracks and almost fell to the ground when I walked in, when she got there, and the room was surrounded. She was surrounded by people. And my friend came running to me and said, no. This is our intake.
This is the intake, yes.
This is the intake. This is our multidisciplinary team. This is every hand that we need. Because in the world of adult medicine, the more people that are around, the worse the situation is, right? And so when I walked in and I saw 11 people at this child's bedside, I almost was like, it's that multidisciplinary way that you all work in any intensive care unit, but we're speaking specifically about PICUs. And the parents are part of that team.
Yes.
How do you advise parents to be a part of that team, how to advocate for their child, how to navigate this intense situation? What is some advice you have for them?
One, acknowledging that the PICU is a strange place for anyone. Even people who have a medical background come to the PICU and say, what in the world is this? What is happening? All of these different things. And I think it's because there's little knowledge about the PICU and what to expect and all of those things. So when people get there, one, we already know that there is a part of you that is going, what am I supposed to do? What am I supposed to think? Do I get in the corner and cry? Where do I go? Am I supposed to stand? Do you want me to go outside? We know that all of those things are going through your head. And in the midst of it, you're also trying to keep a brave face because your child is there, your child or your loved one. I feel like I'm going to say child a lot, but I want people to know that this also applies to loved ones because we understand that family structures are very different.
Families come in all different ways.
All different ways. So if I say child, please know it's the village that has arrived to help be at the bedside. So the first thing I tell parents is, one, know that we know where you are starting from and that we have signed up to take care of families on their worst day.
I love
Every parent that is there, it is their worst day. Any parent that you were to ask, would you trade places with your child right now? They're going to say yes. And it doesn't matter the level of illness. I can have the sickest of the sickest child roll in, and I can have you're going to be okay in a few hours child roll in. The response from the parents, exactly the same. It doesn't matter. So the first thing I would tell families is know that we know where you're starting. Okay. And because we know where you're starting, we chose a field where we want to help you through that, which equally makes you a part of the team and a part of someone that we also have to care for. The next thing I tell parents is that you are still the parent. No one knows your child better than you do. So when I come in the room and I have questions, They are legit questions that I want to know the answers to. If your child is signaling something and I'm looking back at you, it's because help me out. Help me out. There's something happening here. If your child needs support or needs to hear from you, we're going to need you to. And we'll never put a parent in a position where they're not emotionally in a position where they can do that. It's always going to be in a way where we acknowledge, the families need support too. But please know that you are still the parent and we acknowledge you as the parent. And we want you to be a part of the team. Ask questions, make suggestions. Tell us things about your child that we might not have picked up on because you've been raising them for X amount of years and I just showed up and have met them for the last 5 minutes and am hoping to make the best decision possible. But that I respect the fact that you are the primary caretaker and you still are in this position. I am solely a vessel to get you back to your previous life that you had before. And in order to do that, we need parents to be catalysts to that care. Maybe it's talking to a child and helping them understand. The biggest thing I tell families is don't weaponize the position. Like, if you act up, you're going to get a shot. Or these things. Sometimes we hear it, I'm like, no.
No, my husband's a family practice doctor and he says the same thing. But yeah, especially like he said around like 8 or 9 is when he notices parents will start saying that, like, oh, Dr. such and such is going to blah, blah, blah. This because like when you're 3 and 4, when you don't really have a choice, you get held. You kind of get held and bear hugged. But yeah, I love that. Don't weaponize the position. Yeah.
We are here to help. We are a friend, not a foe. Even sometimes when we have kids come in and they come in circumstances that the family's like, oh, you shouldn't have been doing X. And then the expectation is that I am going to come and fuss. Well, I'm not going to fuss because I'm not the parent. I'm going to save and fix, but when it comes to figuring out things, like we're going to coach this together. So I would say recognize that you are the parent, that we are a team, we understand your starting point, and it's okay for you to ask us to slow down. It's okay for you to come to rounds and ask questions. And it's okay for you to say, can you come back later and us sit down together because I'm still not understanding. So be an advocate for your child, still parent your child, and know that we see you as a team member, not as someone we're just talking at, hoping that we move on to the next patient.
What happens if someone feels like they are in that position where they feel like they're being spoken at? They feel like something has happened and there's a divide in the team and I'm on the outs. And I ask because those things truly do happen, right? I think we have this idea of healthcare providers sometimes that there's like a healthcare provider heaven and people come down for their shift and then they do their shift and they go back up. Right. When that's not the case. The case is that everyone is bringing with them all of themselves, their humanity, the good things, the bad things, the great thing that happened in their day, the fact that they got cut off in traffic or got, and they're still personalities. And there are clashes. People may not see eye to eye, not just from a personality, but also a standpoint, but also questions, outcomes, right? Parents may not want a certain treatment. You may feel a treatment is necessary. How do people navigate when you feel like, okay, that therapeutic bond has been broken a little bit. We're on the outs. How do we get it back?
I would say, firstly, hit it head on the front end. Don't wait for days and days and days to come for people who are there for extended periods of time. And now we're on day 7 and we find out, well, I actually never really agreed with this plan or I did not like X, these types of things. Because it's really hard for me to march back that far and figure out how to fix us going forward. So one, the second you recognize, hey, something's off, this isn't working, I don't like this, or I'm uncomfortable with this particular person, let's talk about it.
Address it immediately. That's a big piece of advice. I love that you say it because I give the same piece of advice. Speak about it immediately and to the person closest to the event.
Yes.
Right? Because you want to address it now. You don't want to let it fester, but you also don't want something to happen that you didn't want to happen.
Correct.
And so address it immediately and try to address it. And if I'm speaking out of pocket, let me know, but address it to the person closest to the event. Like, hey, Dr. Nugent, I didn't really think that this tone was appropriate, or how we are navigating this is not consistent with our goals, our values, our capabilities, so address it immediately. I love it.
Absolutely. And then address it immediately, but also find someone that you have connected to that you feel safe to talk to about it. So let's say I'm the person that came along and you're like, you know what? I didn't like how that working relationship worked in that moment. But maybe you don't feel comfortable speaking to me when I come back in later to check on you and your child. Speak to your nurse. Say, hey, I was wondering if, you could help clarify something that Dr. Jacobs mentioned earlier. It was a little off-putting to me, or I didn't understand it, or I felt like she was speaking, above my head and I didn't feel comfortable with interjecting. Because we are a care team. And so that stuff is going to make it back to me. Not in a way that's like, oh, this family in bed 2 hates you, but in a way that's like, hey, this family in 2 is not understanding what's going on. Yeah. Or they have some questions about eggs. So if you don't feel comfortable speaking to that person, then speak to your bedside care team, hoping that you feel comfortable with at least someone, child life, whoever, knowing that I am going to tell you this with the goal that maybe me and the team can sit down to discuss it. The next thing I would say is don't hesitate to have us come back. Sometimes I feel like families may gauge investment based off how many times they've seen me, especially as the attendant.
Oh, interesting. Yeah.
And as the attending, I try to be very transparent with families and say, I make my rounds early in the morning when I see patients. I attend rounds with all levels of trainees, and you'll see me again on rounds. And I usually try to come back after rounds to check in on families. But it is the ICU. And sometimes there's something that happens that will tie up the entire day. Yeah. And it's not that I didn't intend to not come back. It is that there is something that needs my level of attention right now, and that there are many other team members checking on you. And it's not that I don't care about your child. It's that, hey, I'm kind of tied up now. So I try to phrase it in ways that say, ask for me if you need to see me or any provider, not thinking you're monopolizing my time or pulling me away or being a bother, but also know that if I don't check back in, charge it to what I'm doing over here and not to my actual investment in your child's care.
Yeah. Oh, I like that piece of advice. I think something else people may not realize is, though you may not see Dr. Jacobs-Pratt, she is aware of it all.
There's not anything that's happening that I don't know about.
Yes, it's very true. It's very true. There's monitors everywhere. Everything comes up on the electronic medical record all the time. If you're working with residents, they're constantly reporting back to her. Mm-hmm. And so there's always a line to the physician, some way. And so, yeah, and even us on like the lowly medical floors, like I know what's happening. I've never thought about that like people may gauge your interest in how many times you come back to visit in the day, which is, very true. People, because if you are seen, sometimes you feel seen, And so that's something I'm going to start bringing into my practice and thinking about how I can communicate that, like, just because you see me one time today doesn't mean that I'm not invested. I'm going to think about that. You've given me something to go back and think about how I'm going to communicate that to patients. I love that. That's really, really good. So what is the main thing you want listeners to understand about the Pediatric Intensive Care Unit and the experience? This is a long one. So the experience as the provider and what you want patients, because some of your patients will be older, able to voice their preferences, their concerns. So how can you say to like kids who can participate, how do you participate, and their support system? And then also for those of us who just like never think about it, if we ever end up there, what's the one thing you want us to know? So that's a lot. I apologize.
No. It's great. I think that if I were to tell someone like what I would want you to know about what I do and what to do if you land in the pediatric ICU, I would say know that you have landed in a space where everyone there is passionate about children and about families. Because one thing I always hear when I say, oh, I do PICU or PEDS, people are always like, oh, I wouldn't be able to deal with the parents or the families, these things. Well, luckily, there's a nice batch of us who are interested and invested in families. And we are there because we care about families. I could not do adult medicine. The elevator's open and I'm like, nope. How do I?
No, but I think that's very true. That's very true because, again, I had someone say, if you don't love parents, don't go into pediatrics.
That is exactly,
so you have to do that. And then on my side, I spend a lot of time dealing with adult children who are caretakers. And it's a very different dynamic, right? And so you do have to figure out how to navigate the village. And the village looks different in every stage of our lives.
Exactly that. Is that we have signed up to navigate the village, just as you put it. We've signed up for that. We're passionate about it, and we want to be here for that. So you can cross that off your list of things to be concerned about in the sense of, well, I don't want to be that parent or these types of things. Be that parent. We're here.
Be that
We're
parent.
here to help you. We're here to talk to you. We're here to come back, later. We're here to advocate for you. We're here to set up care conferences. We're here to come early. We're here to stay late. Like, that's what we do because we care for children and we care for families. So know that you're in a place where everyone who signed, because we all know that there's a huge discrepancy in compensation and pay when it comes to pediatrics. And so we all have signed up to say we are passionate enough about this, despite so many things that make people say, maybe not pediatrics. So we're here to help you. Know that you're a part of a team and we need you. If you're not an active participant, this is going to be real hard because I'm going to have a lot of guesswork to do for someone I just met. So the more that you can actively participate and help me, the better off we'll be, the faster we'll be able to move things along. And for our older children, use your voice. The fun thing about pediatrics is that there are these milestones. And we take care, I take care of patients who can fit in my hand. I take care of patients who are 2 to 3 times the size of I am. And that is the joy of the day because I don't know if you're someone I can fit in my little pocket or someone who I'm like, I could get a piggyback ride out of here. So it's the joy of knowing that we have this huge continuum of growth and that every phase we have to address that phase. So if I have a 17-year-old and I do see that mom and dad are answering too much for that patient, I'm going to be like, oh, give us a minute. And I'm going to address the patient. So to my parents who have kids who are able to advocate and speak for themselves, if we ask you to go on a coffee run, take that coffee run for us so we can get a chance with your child to find out some answers to questions that maybe might lead us to what exactly is going on. And to our bigger kids, tell us. If we're speaking to you, it's because I want to hear from you and not because I want to take the parent out of the situation, but because the answer is always with the patient. With older patients, they can give it to you.
Yeah, that's really key as you navigate your child changing, how you help your child to navigate healthcare. I don't think parents are ever told that, ever. There's no guide to I'm struggling for words here because my kids are still on the youngish side, right? But I have a 9-year-old and I look to her. I'm like, no, you answer the questions. But then she looks at me and she's like, but you're the mom. And I'm like, no, but I need you to start driving your own care. I need you to be your own advocate, right? And then I think the pediatrician's looking and she's like, you're making this more complicated than it needs to be, Monique. But how long has she had the rash? Right. I'm like, 3 days.
So that you're able to help her find her voice. And I feel like we do things to signal to parents that I'm talking to them because I'll come in the room and I'll sit on the bed with my back to the family. And we'll then engage with the child. So the parents can hear me, but also so they can say, oh, I don't think she's talking to us. No, I'm not. I'm going to circle back to you just a second, but I want to hear from the child. And sometimes it's not even that I think the child has an answer. Sometimes I'm assessing their respiratory status and their ability to speak to me in complete sentences. Like these types of things. But I would need the child to speak to know that that is getting better. So sometimes it's not even that I'm fishing for an answer that makes you nervous. Sometimes it's just that I'm trying to assess the mental status, the breathing. Yep. I'm trying to assess if when I talk to the child, is that heart rate going up? These are the things, but I have to be able to interact with the child. So I would say, know that sometimes we just have to speak to the child. When we do our parent orientation to the pediatric ICU, we make parents come on a little tour where they can see where the coffee room is and get nutrition. They can see where to get their passes, all of that. The goal of the tour is not really that. The signs are everywhere where you can find the nutrition room. It is our opportunity to have that parent outside the room and say, hey, here's the deal. We may send you coffee a little bit later. I'm going to need you to take a coffee break. Or, hey, here's the deal, Mom. You haven't showered in 3 days. We starting to notice. You're going to need to go home.
That was actually the next thing I was going to ask about is self-care through that.
Yeah.
So I had, in the NICU, I had a neonatologist who would very lovingly walk me to the door in the evening and be like, goodbye now. And I was like, what happened? Why? And she's like, you need sleep.
Yes.
Because this child is going to leave here and you will get none.
And it will be your problem then.
Right? Like, she's like, you've got to survive. You have got to survive this NICU stay. Right? And it was the same thing. It was a very short PICU stay, but it was, my friend, the intensivist, walking me to the car saying, you need to be in your bed tonight. Mm-hmm. And you need to sleep because you're going to come back here tomorrow and you're going to be on a 10. And everything is going to be moving fast. And you're going to be asking a ton of questions, right? And you're going to be in this mode. So take a break. How do parents survive the intensive care unit? Because you're right. I would have done anything to be on that. CPAP is what Kay was talking about, one of those machines that blows air into your child's airways. I would have done anything to be that, to have trade spaces with my child. But instead, I was at home, like trying to get some sleep while her father was in the PICU with her. We took shifts, right? That's how we decided we were going to get through this intensive situation. What would you give for some tips on how we as parents would survive that as best we can?
As best we can, I think, is key. Because there is nothing I can do to take away your level of worry when you go home, right? We know that parents go home and they feel guilty for being at home. They feel guilty for taking a shower. They feel guilty for getting a nap. They feel guilty for so many different things. And that is the nature of caring for your child. So we're not here to say, oh, no worries. You're going to worry. That would not acknowledge the gravity of the situation. Now, your kid is in the pediatric ICU, but we're here to make you feel more comfortable and as comfortable as you can. So one, if you have a support system that allows you to trade off shifts in regard to being in the hospital, let's work on that. There's no need for both of you to be here right now. Yeah. Trust that if I needed both of you there and the situation was so emergent and dire that you shouldn't leave, I'm going to say to you, you can't go right now. You're going to have to stay. But if we're saying one of you should leave, then one of you should leave.
Take a break.
Yes, take the break. We also acknowledge that not everyone has someone else to come up to the hospital to stay. And that's okay too. Because if we say you should go home for the night, it's because I think your child is going to be fine clinically enough or well enough for you to be home safely. And that I know I can call you if I need you. I know that you have reliable transportation back to the hospital. I know you're going to answer your phone. So those are all things we think about. So I'm going to ask you, do you have a car? How did you get here today? Are you able to get back here safely? If not, I'm going to see if I can get you a spot at like the Ronald McDonald House or something if I need you to be able to get back here safely. But if I am advocating for you to go home, it is because as the attending physician on, I think it is safe enough for you to leave. I will find you if I need you. Please come back in the morning. You can't pour from an empty cup. You're not doing anyone any good by being at the bedside like this. You're not proving anything to me by staying all the time. You should go. Some people have to go back to work. Some people have other children that they need to get to school and structure that they need to provide in their household. Some people just actually need to rest. We understand that. We are an expensive set of babysitters. Trust me. If I need you, very expensive.
Very, very expensive. I've paid the bill.
Right. Exactly. And this is the safest place. This is the safest, most expensive set of babysitters. If there were no time like the present to go and do something, it's now. So if we're advocating for you to leave, no, it's safe for you to leave. Get out of there. Come back. We'll see you in the morning rounds.
Yeah. Yeah. No, it's very true. Life goes on while you and your loved one in the hospitals. So, and that is really, really key for people to understand. And try not, and I'm going to be preaching, to people who may not hear it, but try not to feel guilty. And the reason why I say preach to people who may not hear it is because I didn't hear it. I 100% didn't hear it when people told me, you need to take a break. I was like, when we were in the NICU, I was like, oh no, I'll call, I knew that the chief nursing officer of the hospital. I was like, I'll call this person and see if they can empty out a maternity bed that's not being used, and I'll sleep in that bed. And they were like, no, you need to go. You need to. And I felt guilty. I felt anxiety. I felt all this separation anxiety of I was supposed to come home with a child, but I left the child there. And that was the NICU then. And then the PICU was a whole different set of feelings because things progressed. You know, we thought we were okay. Oh, maybe a little bit of Zyrtec will get, and then it was like, boom, but nope, we're not. Oh, that's a lot of oxygen. Whoa, whoa, whoa. 8 liters is like, even for me as an adult, that's an alarm, and now it just went up and went up. And so things escalated quickly. And you often are in that situation, is how you got to the PICU, is that things escalated quickly. Something changed rapidly that you didn't expect. And you ended up in the intensive care unit. And then, as a parent, you're just like, I no longer am in control, right? You would think, my friend is the attending, I'm a physician, my husband is a physician. You would think that we could participate in a way that, would be like textbook, like, wow, they did it great. No, I was just like, what do you need?
Yes.
What happened? Yes, she has 10 toes.
Yeah. Right. Yeah.
Like every piece of medical information, every piece of confidence I had went out my head, And so, I want parents to know that, there are healthcare providers, from the attending to the nurse to the resident to child life specialists to the respiratory therapist. They see you.
Yeah.
They see you and they know that you're going through all of these different feelings. And a hospital stay for adults, maybe for children is different, but a hospital stay for adults rarely makes things easier. Mm-hmm. It makes things different when you leave.
Right.
Oftentimes my patients are leaving with a new prescription, with a new walker, with oxygen, right? Your patients may not immediately leave. They may get downgraded and spend some time on the general medical wards. But oftentimes when you leave the hospital, we didn't just go back to daycare.
Right.
We were in the shock of like, oh gosh, what happened? I had a conference and I'm canceling conferences and I'm doing conferences virtually, not getting my CME money reimbursed because I was supposed to be somewhere and I wasn't there,
right.
And so, this will continue. And so you've got to know it's a marathon.
It is a marathon. It continues. And like you said, you show up and even the most medical of families are like, what in the world? Yeah. And we laugh about it later once things are better. And I'm like, remember how you came in here with no shoes on and no pants? It just becomes a thing where we're like, I've seen it all, because you didn't pack a go bag for this. You called the ambulance. They took the child. You came in barefoot. Yep. That's how we are. So we're used to seeing that, and we're used to helping families figure out what does the new normal look like going forward. Because we get those questions. Do I need to put them in a bubble now? Do I need to change this? Do I need to, do X, Y, and Z? And we help families navigate all of the uncertainty that comes with how do we recover from this? And how do I get my child to the best that they're going to be after graduating from the ICU? And that's a scary thought. But we love seeing patients come back because we have little reunions and picnics and all of these things.
That's great.
We love seeing the kids, and sometimes they're unrecognizable. I always recognize the parents. Mm-hmm. If you told me a child story, it would take me a second. But if you showed me a mom or played the voice of a mom, I would know exactly what room we were in the time of year that it happened and about the child. I'd never forget the parents.
That's beautiful. My patients don't come back. My patients want nothing to do with us after they leave. The adults are like, goodbye. You guys have picnics. And this is the great thing about pediatrics and why I love having pediatricians on the show. It is a different world. It is a world of joy. Yeah. It is a world of promise that you don't recognize the child because they got so big.
Exactly.
They got so healthy, right? And that's why I love having pediatricians on to talk about this, because, everyone always says, I couldn't imagine when they talk about things happening to children. I couldn't imagine. And that's not the case. It's that we don't want to imagine. You can imagine. You can very easily, as a parent, go to that place in your head. You can imagine, but you don't want to imagine it. But there's a place and a group of people there to catch you for the thing you don't want to imagine. And I want you to take Dr. Jacobs-Pratt's information and use your voice, take a walk if you need to, speak to the person closest to the situation, and if you have a disagreement, a concern, a problem, speak about it immediately. And know that your pediatric intensive care attending knows all. You may not see them all the time, but They have checked in on Epic, which is one of the electronic medical records that's used in this country. But they have checked like 27,000 times. They have looked at that. And there's always a way to get in touch with your pediatric intensive care attending and the team. So this is exciting. This was a great conversation. And it's usually at this point where I say to people, do you have a book or a TV show that tells us your message? But you have a book.
I do.
Because you wrote the book.
Yes.
So please tell us about The Magic Bonnet, Zoe's Hospital Adventure.
Of course. I mean, I have it right here. Of course I do.
Love it.
Yes. I love this book. For me, okay, so this is a children's book, and I'll tell you about the premise of the book shortly, but I always have to tell people that for me, the book is my love letter to medicine.
Oh.
During COVID, medicine was hard. We went back to adult ICU medicine. We were doing all kinds of things that I thought to myself, I got to get out fast. Where is the exit? This is not what I thought I was going to be doing. And there was a voice in me that said, you got to pause a little bit. Like, don't get up here that fast. You need to reconnect. And hair was a way that I found to reconnect. And what started with doing hair for patients in the hospital, just to say, you know what, yes, I am Dr. Jacobs-Pratt on rounds, but I'm kind of a friend that's a really good braider. Yeah. In my off time, really became a lot of fun. It was a connection to patients, and it quickly snowballed into me bringing plastic bags from home with some travel size hair care products from Target, Amazon, Walmart to the hospital, supporting this hair work, resulting in a whole product line now that supplies hair care supplies for people with hair that looks like mine. Sister locks, braids, curls, coils, weaves, all the different things. In the midst of that, sometimes when you do work, your wildest dream you can't even imagine. And in my wildest dream, I would have never imagined that this would span 6 states. And I just watched it grow and grow and grow and outgrow me. And I have loved that. But I needed to find a way to bring it back home and put it in writing. So the book, The Magic Bonnet, Zoe's Hospital Adventure, is inspired by true events, bringing bonnets and other hair care supplies to our hospital system. It's about a little girl who gets a magic bonnet while she's in the hospital. Every day she wakes up with a new hairstyle. It helps celebrate the cultural identity that exists behind hair. It celebrates the meaning behind hair, why it's important to us, and why it needs to be cared for the way that it does. She wakes up with bantu knots and locks and braids and straight hair and puffs and cornrows and all of the different things that make hair a part of our identity. So I tell people all the time, the book is a great book to learn about identity and inclusiveness and inclusive care. But for anyone who is in medicine or pursuing medicine, I think it's a stark reminder that if you have an idea, pour your whole heart into it. Take it and run with it. You would never tell me that I would go from pediatric intensivist to now an author who's selling books about some of the work that I did in the hospital. So part of the proceeds go on to continue to work to help support hair equity work that I do in the hospital. So the book is available on Amazon. You can also find me on my social media. I talk about where the book's available there or where I'll be doing book signings live. So yeah, follow my journey, follow this book. I hope it's the beginning of a series that I want to call Hospital Hair. So most I'm going to say about the series now, but I hope that it's a whole children's book series, and I just love it.
I love that. There's a lot of healing in touch. Mm-hmm. And in caring for yourself, like what you wrote in your intro, helping patients feel seen in the hospital. And I can tell you, when I walk into a room and somebody's daughter has come by, washed, braided their hair, put on a little lipstick, the patient sits up a little bit different. Mm-hmm. They feel seen and ready to be seen.
Absolutely.
And there's something very healing about touch. And, I have been known, not often, but in a few times, to cut nails, file nails, because it's one of the things that we don't do in the hospital is cut fingernails. Right. I learned that pretty early as an intern. And in the ICU, people would be there for quite a while and their nails would grow out, and I would be caught a few times as a resident cutting and filing nails, because it's the small ways of continuing to give people their humanity and have that healing touch. Yeah. And so this is amazing because children are no different. They want to be seen. They want to be cared for. They want that healing touch. They want their hair done. They want to feel good. They want to look good. And so I love that you have expanded this to 6 states. So keep on. I know you're going to hit all 50 pretty soon. I hope so.
That is my hope. Yes.
That's going to be great. Well, this has been a great conversation. This is Dr. Nakia Jacobs-Pratt. She's our pediatric intensive care attending who spent some time speaking with us today. Thank you so much for being here. Where can our listeners find you, your book, and anything else about you?
Thank you for that. I am on Instagram at HeyIsKMD, so HeyItSKAYMD, and I go by Hey, or I use Hey is K because that's how I answer the phone in the hospital. So it's kind of my tagline, HeyIsKMD. That is also my website, so it's www.heyiskmd.com. Also on Facebook as K Jacobs-Pratt. So all in the same, trying to keep it as consistent as possible. You can find me on Amazon as well with my children's book, The Magic Bonnet. So on Amazon for $14.99 or the Barnes & Noble website.
Wonderful. And all those notes will be in our show notes, where you'll be able to find all her socials, because this is someone I want you to, know is a source for you, resource, great person. Thank you so much for spending time with us on the Prescription for Admission podcast. So this has been the Prescription for Admission podcast. I'm Dr. Monique Nugent, your hospitalist. I'm also the author of Prescription for Admission, the book. I usually say it's because I lack creativity why I named the book after the podcast, but then someone said, stop saying that. It's your marketing. You're smarter than that. It's marketing. So they're both named the same thing for my marketing, because my marketing is consistent. So, so if you're listening to us anywhere, like and subscribe. You can find us anywhere you listen to podcasts. We're also on YouTube. So check us out on YouTube and click the follow, subscribe, like, all that stuff. Thank you so much for listening to Prescription for Admission. You have a great one. Bye.